Meet Jane. Jane is a 5-year-old who came in with her parents and is being seen by her pediatrician, Dr. M. Changes. Jane has a 2-week history of edema. Her parents say that her entire body is swollen. Dr. Changes did a physical exam and ran some labs. Her urinalysis reveals a 5+ protein and an albumin to creatinine ratio of greater than 350 milligrams per mole. Jane's parents were curious about what was going on, so Dr. Changes decided to explain the process of proteinuria. Proteinuria is classified into 5 mechanisms: glomerular, tubular, overflow, functional, and orthostatic. Dr. Changes decided to focus her explanation on glomerular proteinuria since that is the most common cause in children. In order to understand glomerular proteinuria, Dr. Changes first decided to describe the glomerular capillary structure. There are 3 layers separating the urinary space from the capillary lumen. Closest to the capillary lumen is the endothelial cell layer with multiple fenestrations. Next is the glomerular basement membrane, or GBM, and finally, if we pass the GBM, is the podocyte layer that wraps itself around the glomerular capillaries. Normally, all 3 layers work together to form what is known as the glomerular filtration barrier. This barrier, in a healthy individual, facilitates the passage of plasma, water, and small solutes between the capillary lumen and the urinary space, while preventing larger molecules such as albumin from passing. The role of the GBM in this barrier is through its structure, a tightly interwoven mesh of collagen, laminin, agrin, and nitrogen that is thought to impart the size and charge selectivity properties of the filtration barrier. When any of these layers get damaged, either by a chronic insult or a genetic defect, it results in a barrier that can no longer efficiently filter out charged or large molecules. Therefore, when large amounts of protein are found in the urine, it can be an indication that one of these layers in the filtration barrier is somehow damaged or defective. Dr. Changes explained that there are 4 other mechanisms of proteinuria. Sometimes smaller proteins, such as immunoglobulin light chains, can pass through the filtration barrier, but are usually reabsorbed in the proximal tubule. Tubular proteinuria is when the reabsorption within the proximal tubule doesn't occur due to damage to the tubular cells, such as acute tubular necrosis. In overflow proteinuria, the cells of the proximal tubule are healthy, but there is simply too much protein to reabsorb. Overflow proteinuria can be caused by conditions such as multiple myeloma, where the body is producing massive amounts of immunoglobulin light chain. Another mechanism is functional proteinuria. Functional proteinuria occurs with an increased amount of renal blood volume. The increased amount of protein to the nephron can exceed the reabsorption capacity of the proximal tubule, resulting in small amounts of proteinuria. Functional proteinuria will resolve when renal blood flow returns to normal. The final mechanism is benign orthostatic proteinuria. This type of proteinuria occurs when the patient is awake and active, but resolves when the patient is supine. The exact etiology of orthostatic proteinuria is not well understood. Jane's parents appreciate the explanation of why her urine protein levels were increased, but want to know why she looks swollen and puffy. Dr. Changes thought for a moment, then realized she needed to explain some physics. She proceeded to tell Jane's parents how the body maintains fluid balance through balancing 2 major contributing forces: the plasma colloid osmotic pressure and the capillary hydrostatic pressure. She started off by explaining the plasma colloid osmotic pressure, which is the pressure that maintains the fluid levels in the intravascular compartment. The presence of proteins, primarily albumin, which are unable to easily cross the capillary wall, pull fluid back into the vessels. Opposing this pressure is the capillary hydrostatic pressure. It is the physical force of the fluid against the vessel walls, which allows the fluid to leak out of the vessels. Jane's mom is an aerospace engineer, so tracks with the physics, but still doesn't understand why this means Jane is swollen. Dr. Changes then explains how glomerular proteinuria can cause edema. She reminds Jane's parents how, in the case of glomerular proteinuria, there is a loss of albumin in the filtrate. This causes a significant decrease in the plasma colloid osmotic pressure, which causes a decrease in the fluid pulled back into the vessels. This fluid accumulates in the interstitial space and within tissues, causing them to swell. This accumulation of fluid is known as edema. The decrease in the intravascular volume triggers the activation of the autonomic nervous system, which induces peripheral vasoconstriction, an increase in the heart rate, and an increased myocardial contractility. The decrease in the volume also reduces renal blood flow, and this is sensed by the juxtaglomerular cells, which in turn activate the renin-angiotensin-aldosterone system, or RAS. The end result of the activation of the RAS is net sodium and water reabsorption in an attempt to correct the depletion in intravascular volume. However, because of the continued decrease in plasma colloid osmotic pressure from persistent albuminuria, this reabsorbed fluid continues to shift into the interstitial space and exacerbate the edema. Jane's parents want to know how all this information relates to their daughter. Dr. Changes explained that their daughter most likely has nephrotic syndrome. Nephrotic syndrome is characterized by greater than 3 grams per day of proteinuria, hypoalbuminuria, and edema. In children, there is often periorbital edema, especially in the morning, as well as edema in the ankles, feet, and abdomen. Dr. Changes explained that nephrotic syndrome is a type of glomerular proteinuria. The major nephrotic syndrome that occurs in children under age 6 is minimal change disease, where there is damage to the podocytes. Dr. Changes says that they could use a biopsy to diagnose minimal change disease, but since it is extremely common in children, they will just empirically treat Jane with corticosteroids. She explains that there are other primary causes of nephrotic syndrome less common in children, including membranous nephropathy, focal segmental glomerulosclerosis, and membranoproliferative glomerulonephritis. Dr. Changes also discusses possible complications from nephrotic syndrome. These include venous thrombi, acute kidney injury, spontaneous bacterial peritonitis, an increased risk of infection, and hypovolemia. The complications are primarily due to loss of proteins. The loss of antibodies causes an increased risk of infection. The loss of anticoagulants causes an increased risk of blood clots that may form venous thrombi, and the loss of effective arterial blood volume because of general protein loss can cause hypovolemia. Jane and her parents were happy with this explanation. Jane went home on corticosteroids, and they all lived happily ever after.
Created using Powtoon.